You're both doctors. Hello and welcome to today's social media live from the World Health Assembly, the 75th of our organization's history. And thank you very much for being patient and bearing with us. And now I'm even more glad that we finally managed to come to you and have you with us here to this very important topic. We're talking about primary health care and universal health coverage today. Terminologies or topics which are coming up nearly every time in the discussions we have around here with the national experts, with the ministries, with all the 194 member states that are currently joining here in Geneva for the World Health Assembly and discussing all health topics that concern them and concern the world. So my name is Christian Lindmeier. I'm very happy to be joined today by two of our experts. First we have Jim Campbell, who is Director Health Workforce at WHO. Thank you very much for joining. And we have Dr. Shannon Barkley, who is our expert on primary health care. And let's start right away. No, before we start, let me remind you that you, of course, can ask the questions on Twitter. We have you, please ask on #AskWHO. And we also have a live today on Facebook, on LinkedIn, and on YouTube. And on those three platforms, you can use the comment section to bring through your questions, and I'll take them right from there. So off we go, and let's start with what is actually what we call PHC and UHC. What is primary healthcare? Shannon Barkley, please help us out here.
Thanks so much for the question, and thanks everybody for joining us today. Primary healthcare, to understand primary healthcare, you have to understand really the foundation of why we are all here at a gathering like the World Health Assembly. And it's because over 70 years ago, the world enshrined and governments backed up that it is a human right for people to have the highest attainable standard of health. And so what primary healthcare is the how to get to that. It means that people are able to live in environments that keep them healthy as long as possible, and that when they get sick or when they need a specific health service, they're able to access those health services as close as possible to their daily lives. And what that results in is not only a healthier population and that everyone is able to get health services when they need them, it means that it also happens in a more equitable way, meaning no one is left behind in the discussion.
All right. Now, the other terminology we're dealing with is universal health coverage, and I'm very curious to hear what that is all about. Jim Campbell.
Christian, thank you. Good afternoon, good morning, good evening, wherever you may be. As Shannon said, the PHC is the how, UHC is the what. It is that ambition, that goal, that objective, that every person, all people of all ages, of all sex and all ethnicities have that access to health services with the medicines, the quality opportunities, the vaccines, and ensuring that they have financial protection so that it's not only the access to the services, but it's affordable or it's subsidized or it's not going to cause a catastrophic impact on a family, an individual, or their income. So it's the goal. The primary sales, the how, the UHC is the goal.
Now, how does this benefit, first of all, the primary healthcare, maybe, Shannon? How does this benefit the individual? Why are we, as an individual, the families, the women, the mothers, the children, the fathers, why are they concerned about primary healthcare? I mean, I'm going to a doctor when I feel sick, or I go to the hospital if it's an emergency. Is that primary healthcare already?
It is, in fact. I think people care because we all care about our health. We care because health impacts our ability to live the life that we want, to have healthy living, to be able to accomplish the things we want, to have the relationships we want in life. Health is really the foundation for all of that. And so it matters because then what happens if I get sick or if I need a health service and there's no one nearby to be able to provide that? People are often then having to travel long distances to get health care in places far away where it could be too late, or they're having to pay more, to Jim's point about universal health coverage and the importance of healthcare being affordable. In the primary care setting, meaning where services can happen close locally with your community health worker, with your nurse, with your doctor, right there in your community, it means that you're able to get the services that you need. And when you do it that way, as opposed to through really expensive platforms like hospitals, when it can be delivered safely and effectively at primary care, it means that the cost to the system and the cost to the person is less. So we're able to keep providing services for a longer time.
Now, countries are supposed to invest, of course, in public health, primary health care. Does every country need to do that? Do they all have to do it the same way? Does it mean that every person in the world has to have a hospital in a certain distance away from them? What's expected? And some countries are way further advanced, and it will cost them way less to renew, but therefore keep the system up, whereas others have to basically nearly start from scratch. What's the importance here? What's the feasibility?
You're right. No two countries are the same. Every country has taken a different journey on the development of their health system, but every country has somewhere that they can improve. No health system is perfect. And so I think, for countries that have had a more, shall we say, more developed system over time, often that's about actually recentering the health services back closer to people. Sometimes those services tend to get oriented much more toward hospitals and centralized, when in reality what people might need is a service much closer to them in their home. I think we're seeing new ways of doing things that have been, the doors have been really flung open through the COVID pandemic, where the delivery of digital care, people being able to access services without necessarily contacting a location, but still having access to that health provider who's so important to their well-being. So I think, the how-to, there's no one size fits all. There's no roadmap for every country, but the principles hold the same. And so it's really about helping countries figure out how they use their resources that they're investing in health most effectively to make sure that their people have access to health services when they need them.
I want to come back on a point you just mentioned, because COVID, as you pointed out, it is said around the world that COVID showed us the weaknesses of the healthcare systems, of the health systems, and of primary health care. It showed us also the importance of primary health care. Maybe back to you, Jim. What besides primary health care, what other aspects of health systems can be or need to be strengthened in order to achieve this universal health coverage?
So on your first point you're asking there, Christian, the impact of the pandemic on our health systems. We've got evidence from the member states and the discussions here in the Assembly that it really has a substantive impact on infections, on hospitalizations and deaths, but it's disrupted and taken us backwards on access to essential health services, whether that's for cancer, diabetes, non-communicable diseases, communicable diseases, maternal health. And there's some suggestions that for every death we've seen from the pandemic, the burden of mortality, the burden of deaths may be double or even triple for the impact of it, because our health services, our health systems have taken this real shock. So as we're moving forwards and recovering from the pandemic, I think that there's some real lessons that can be learned for how do we achieve this goal. We need one healthcare system, an integrated health and care system. It has to deliver the essential services for the communities and the people as close as possible to them as possible. It has to deliver what are the public health requirements: health promotion, health prevention, keep people out of hospital, keep them at home, make sure we've got healthy lives, making sure we're understanding the opportunity to interact with the planet and with our food, and ensure that we're not putting ourselves in danger in a health condition. And other surveillance of disease and other functions that come through. We have to do that as close as possible to the people and make it affordable. And then we have to ensure that we've got capacity to respond to an emergency when it's needed. 5 things. The assembly, the ministers are talking about these 5 things that have to be done coming forward. We've just had a fascinating conversation with ministers, with the World Bank, with our Director General, with our regional directors on exactly this. What can we do? We know the evidence, we know the problem. When do we act in a convincing, coordinated way?
Thank you. And actually, Tawanza Hassan from Arsenal LinkedIn, one of the areas, what are the coming initiatives to support pediatric primary care? Is there anything coming up? Was there anything discussed today at the meeting? Because he says children are often left behind. What do you think?
We've seen the progress that we've seen on universal health coverage. The World Health Organization with the World Bank measures this. And we look at a basket of indicators to actually make, including childhood illness, including childhood mortality and morbidity, but also maternal health, infectious disease, the capacity of the healthcare system, the capacity of the people who provide care, the health workers. And overall, we've seen progress in the last 20 years. From 2000 to 2019, unprecedented progress worldwide, which we should be celebrating, and including the impact on children. It's still not enough. We have to do better. But the COVID impact, we are now concerned that we may have taken several steps backwards. So we have to redouble our efforts as we move further forward, looking at all members of the community, whether that's infants, children, adolescents, women and girls, men, the elderly, across the life course, to make sure that we can hit every indicator.
Thank you. So in case you joined just now, we're here on social media live from the World Health Assembly 75 in Geneva, and we're talking about primary health care and universal health coverage. Thank you for everybody joining us on Twitter, Facebook, LinkedIn, and YouTube. And to ask questions, please come in on hashtag AskWHO on Twitter, or use the comment section on the other platforms. And I'm coming right back to another principal question which we touched on, and actually Professor Dr. Latif Bouya asks whether there is a difference between primary care and primary health care, and what is it in case there is?
Question, and one you're not alone in asking that. It's one we come across often. So yes, there is a difference between primary health care and primary care, though in countries those words are sometimes used interchangeably, or one country might use one of the terms to mean something that at WHO we might mean the other. At WHO, and the way that we've brought together countries around these ideas, the way we divine them differently is that primary care is really those first access services. It's where you go when you have a new health problem most of the time, if it's not a really severe emergency, when you might want to go to the hospital. And it's a place where you can get continuous care from a care team that knows you well, from care providers who know you well. They can follow your health across your lifetime. Now, primary health care is a bit different in that it takes that really important function of primary care and places it within the broader health system and the transformation that needs to happen in the whole system. So it basically says, as you design your integrated health services, you need to really value primary care, and you really need to value prevention and promotion, whether those happen in primary care or somewhere else in the health system. But it also says that even one step beyond that, our health system has a role to play in making sure that policies and actions are taken to make our environment a healthier place to live, to give us better air to breathe, better water to drink, ensuring that our food sources are safe, ensuring that we have safe places to cycle and bike, making sure we can get exercise, that these environmental changes are really put in place to address what we call the determinants of health, or the things that make us well or sick. And then it also says that people need to be given the power and the ability to care for themselves as effectively as possible. People only interact with the health system really a minor fraction of their life. Even people who have a lot of chronic illness are only sitting with a care provider less than 1% of the time that they're on this planet, which means that most of the time we all are making decisions and are expected to make decisions that impact our health on a regular basis. So primary health care requires that people have the information that they need to make really good choices about their health and to manage their health care as well.
And whether to go for health
And where to
immediately,
go.
health care immediately, or whether it's something you can treat maybe quietly at home.
Yes, exactly.
A really interesting comment, and I think we come right back to you, Jim. Primary health care should be made available to the poor, Amrenda S. is commenting. We're right back at the equity question and the universal health coverage, I guess. So, yeah, how to sum that up? How feasible is this? Is everybody in this world supposed to have the same access to health care?
In the constitution of WHO, exactly that. That's what member states agreed 75 years ago, that everyone has the right to healthcare. But obviously, countries are at different stages of economic development, the ability to fund their education, their health, their social protection systems. But we've got lots of evidence to say how to use those resources in the most efficient, the most effective way to respond to your priorities in your population, depending on how young your population, how old, whether the maternal reproductive issues that are there in the country, whether or not non-communicable diseases, whether cancer is a big burden or it's not. In a young population, you have less cancer. So you don't have to have the same services, the same people, but you need the same principles of access and affordability. And that's where we are especially concerned with the access for the poor. I said we're measuring amazing improvements in overall coverage and access. But the second part, in terms of the financial protection, the affordability, we're still seeing, 1 billion plus people where this is not yet available. And that tends to be the vulnerable, the poor, the rural, different ethnic groups in countries. And that's where we really need to put a combined. If we believe in equity, if we believe in all people, in no one being left behind, that's where we need to focus.
That's the mission and the vision of the World Health Organization, which was, as you pointed out in the beginning, enshrined in our early days in the Constitution. Yeah. We have several comments, and that's really good, which asking about the role of health insurance in achieving universal health coverage, because health coverage is very often associated, of course, with insurers. So maybe we can comment on that. What's the role of insurers to achieve UHC?
Absolutely. So in terms of how governments provide this access to care, which is not going to have major catastrophic burdens, it's a public stewardship role in terms of the funding from domestic resources, from tax-based income, from out-of-pocket expenditure, from prepayment insurance mechanisms, the different tools that are available. And we need to tailor that to the country context and the situation. Insurance models often depend on a lot of formal employment, so that you can actually find mechanisms to deduct your contributions to your health insurance, your prepayment. So in countries with less formal employment, you've got to look at other options and other opportunities to do. But it's a public financing, public stewardship role. The provision of care can be public, private, faith-based, in partnership with the government, aiming for the public purpose, not aiming for the commercialization of healthcare at the expense of individuals and families.
Thank you, Jim. Let's come back to I think primary health care. I have a comment that I'm trying to. It's coming in through Twitter through Ask WHO, and it says the poorly planned or poorly delivered diagnostic stewardship is a weakness in primary care delivery. So is it a contributing factor that is delaying the right first time or immediate prophylaxis?
Yeah, I think, one of the things that makes primary care unique is this diagnostic function in the health system. So people don't come to their primary care provider saying, I have malaria or I have diabetes. They come with a problem that they're encountering in their life, and that has symptoms and it has signs, and they work together with their provider and all the diagnostic resources out there to find what is causing this problem and therefore what is the right treatment. And so a huge portion of the work that primary care providers around the world do is making sure that they have the right diagnosis for people. Unfortunately, we know that in a lot of settings around the world, we have the best data on this actually from low and middle income countries, which is interesting, that in some settings it's a coin toss. You have about a 50% chance for even common conditions of getting the right diagnosis when you go to see your provider. Now that has lots to do with the difficult situations that our providers are practicing in the constraints that they have on their time and on their resources, but it also has to do with how we equip and train them, and we can do a better job at that. Now, I think the other tool that is important there is making sure that they have the right diagnostic technology and that they can access that and that that's fed back to the provider so that they can make the right decision. But certainly this is something that we need to work on globally, is ensuring that the quality of primary care is there, because we know that when primary care is high quality, it's able to address about 90% of a person's healthcare needs across their lifetime. We see that from settings in which we have the highest performing primary care, and that role in the health system has huge impact in terms of overall life expectancy and in terms of the equity that Jim was talking about earlier.
Now let's come to an important point at this moment. So this week a roadmap was launched at WHO, or by WHO, to strengthen the national workforce capacity, Jim. Can you flesh that out a bit? What is this about?
Well, in tomorrow's debate in the Assembly with the ministers and the representatives is a substantive item on the people, the health and care workers, the people that we've relied upon during the pandemic, who've been there to care for us, the people who are doing the public health emergency response, the people, unfortunately, who are under attack and violence around the world. And so how do we support them? And there's two elements to this. One is looking at what I talked about earlier. We have to provide the essential health services. And so what do we do with that? And then the other is the public health and the emergency piece. And we need to look at this workforce, one workforce that is there to maintain our health and there to respond when needed to some of those emergencies. There's not two workforces, it's the same person. So we're looking at what can we do, and it's a roadmap which lays out the actions on the public health side and the essential health services side. And it really is not rocket science. These are people. And as Shannon was saying, most of us, when we interact with the health care system, you're interacting yourself as an individual with a care provider or with a team of care providers. It's a relationship between people. We use digital tools and technologies to enable that, diagnostics and therapeutics, but it's still about that people. So how do we have their education? How do we pay them properly? How do we support them? How do we make sure their rights and they're protected in the workplace? We've all seen the pictures of the health workers, after 12 hours in a hospital with the personal protective equipment, coming out exhausted. What do we do as employers, as organizations, to protect those people so they can protect us? And we're really looking forward to this discussion tomorrow. We have one action plan on working for health. It's about the workers who provide healthcare, the people, and then the roadmap on the public health. And these actions then need to be carried forward.
And that's actually going across the development level from countries. This is not something unique to only less developed countries or more developed countries. This stress on the individual healthcare worker or health worker is unique. I mean, everywhere. It's universal.
It is universal. As Shannon said, every country is slightly different, but it's still the people relationships are the same. The education, some of the job titles, the occupations are similar. We have physicians, nurses, midwives, pharmacists, community aides, therapists, all over the world. But we still need to treat them with the respect that they deserve with decent work so that they are in a position to provide the services that we need to the population. And it's a dual relationship, and to guide people in their health-making decisions, to guide the policy debates, to guide the investments.
Yeah, thank you. Again, if you're just joining us now, we're live here at the World Health Assembly in 75 for the World Health Organization. We are talking about primary healthcare and universal health coverage today. I'm very glad we're going through this, and we have many comments actually here, and it's really difficult to select some of them, but I'm trying to cluster them a bit. Actually, one is interesting because it goes to our basic principle. On Facebook, Al-Hagi Nie is stating that healthcare is not a privilege, it's a basic human rights. I mean, I'm not sure if he read that from our website, from our mission statement, but this is what World Health Organization is actually all about. Shannon, maybe you want to just use a few words on that.
Yeah, I think, we touched on this briefly talking about the WHO Constitution, which was established, more than 70 years ago. It is reiterated in numerous UN documents. I think it's safe to say that everyone here agrees with that statement, and I think that's a great place to be starting from, that the governments around the world all agree and are coming to the table around health because they believe it's a fundamental human right. And I think casting it in that light and remembering the weight that holds and its role in broader sustainable development, that we're not healthy just because it's nice to be healthy. We're healthy because that leads to our ability to live longer, more fulfilled, more interactive lives, to be contributing members of families and societies. Like, it's really at the base of what it means to be human. And so I think, all of those rights are tied together, and that's really established and really visible in the way that Sustainable Development Goals were written. So it's great to see that reiterated.
Yeah, well, again, and another handful of comments really is going also on something we touched upon before on Facebook. Siva Kar is asking, what is the WHO strategy for primary health coverage in developing countries, and how is it implemented? So we're coming back to the basic human rights. How do we make sure, or can we make sure, what are we asking from member states, that this basic human right is actually available for everybody? Or no matter what country, what about those unemployed? As we talked about health insurances and healthcare systems, what about the unemployed ones or the retired? What are they supposed to do? So I don't know if we can put this in one answer, in one package, but Jim, maybe what is the WHO effort? What are we trying to do to get member states to come to a certain minimum level, or to get everybody assured this basic human right?
Indeed. And that's what we've been doing for 75 years, and through the roles with government, the roles across different United Nations agencies, the right to maternity care, the right to sickness and protection, all the other social protection measures, as well as the overarching right to health. Data, science, is at the heart of that debate, that discussion. Through the data, we can see which members of the population in countries are furthest behind on this equality and the equity. Who have been left behind, who are the hardest to reach, whether that's for vaccination services, whether that's for childhood pediatric services, maternity care, all the issues across the life course. And then how do we try to make sure that government policy, national policy, decentralized in some countries, a federal level and decentralized states, that we target those. Every country has levels of disparity, levels of inequity that have to be, first and foremost, part of that policy discussion. And to all the people, I'd say that many of you may be old enough to vote. Many of you have an opportunity to influence this right to health through your parliamentary processes, through your engagement with your members of parliament, your senators, your congresspeople, whatever jurisdiction you work in. Express your concern. This equity, this health for all is part of your society, it's part of your community. Vote for it. Don't accept when countries don't put vulnerable groups and equity at the heart of what they do.
an important point that it's not WHO who is implementing those principles, but we are the ones at such assemblies like now and in our many guidances and principles who flesh out what the principles should be and what are the basic things that should be implemented. And then it's up to member states through their process to implement them and to make them available for the individual citizens and in their systems. Let me see what else we have. Maybe back to the workforce. For high quality health services, asked Catherine Kane on Twitter. It's important that health workers are able to diagnose patients, the right training, the right skills, the right training, the right diagnostic tools. We touched upon this before. What are key assets we're doing? And then I have a second question for you, maybe Shannon, afterwards, because we've been talking about what we're asking and what we're doing since 75 years. And I want to know actually about some of the progress we made already, because we're talking about what we're asking, what we're demanding, but maybe we should also point out where we come from 75 years ago, as you pointed that we've been there, and where we are now. So let's start with the training and the skills for the health workforce.
Thank you, Christian, and good afternoon, Catherine, wherever you're connecting from. The evidence, again, science, the evidence that we have is that we have to understand what the population needs. What are the major services to respond to their needs? From that, we can calculate the sort of clinical tasks, the public health tasks, the prevention tasks. And then we need the people with the skills, the competencies to do that at quality, at scale, time and time again. We have guidance from WHO published just before World Health Day this year on the essential competencies for universal health coverage. Again, that sets the information that every government, every school, every health facility can be using to make sure that their people, their workers, have those competencies to do it. We have guidance on how to ensure that we can pay for that education, that we can get the long-term investment and the continuous education, lifelong learning to maintain those competencies. But we've got to implement this everywhere and bring everybody's standards and the quality. Come back to UHC, it's access to safe services, it's quality services, not just to services, as Shannon said, where it may be a lottery whether you get the right diagnostic. We want to hit the 100% in terms of your engagement with your care provider. And that's through education and the tools and the technologies that we can do that.
And now to point out a bit, again, what the achievements were. Where are we coming from 75 years ago in terms of primary health care? Where are we now, even if we made some backstepping maybe in the last 2 years, as Jim pointed out before? So what are our achievements? What can we be proud of as WHO, but also as society, as human society?
There is actually a lot to celebrate, and I don't think we do enough of that in public health. We, as people who are trying to solve problems, I think we see the problems first, sometimes before our successes. But there is a lot to celebrate. Now, the data I'm going to share with you is often data from before COVID, because we don't yet have the information we need to talk about exactly how far back we're going to be in the grand scheme of things. But before COVID was hit, we, in the era of the Millennium Development Goals, we saw under 5 mortality halved. That is incredible. That means that, in a country where a woman would typically lose one of her children, that wasn't happening anymore. We're seeing dramatic changes around the world, and what that means for people's well-being, for their ability to live happier, healthier, more productive lives is enormous. We have great success stories that we just heard in the meeting we were in on PHC from Thailand, and I think Thailand is often held up as one of the great success stories for both PHC and UHC, where they've invested in their communities, invested in community-based healthcare, ensured that people have access to health services, ensured that the services that are delivered are high quality, taken steps over the decades to expand the services available, done that in a really thoughtful way, made sure people have access to teams of health workers and protected them financially so that their whole life wasn't set back when they ran into a health problem. And there are stories like that all around the world, and more are coming. We're seeing, with the commitments from the Declaration of Astana and the UN processes, these new commitments that governments have made on primary health care and also on universal health coverage, we're seeing the action happen. We're seeing big forums on primary health care in Nigeria just happened. We're seeing places like Kenya where their entire national health strategy is centered on primary health care. And it's happening really the world around. And so it's exciting to see that progress. I think there's a healthy dose of realism about how much work we need to do and how much we have seen from the lessons learned in COVID around particularly the equity agenda of groups that were left behind, being left behind even in times of emergency, and the impact of those health services not being available. Those groups that are traditionally left behind will carry an even bigger burden of the consequences of that. And so our health systems need to be more equitable. We need to find a way to make sure that populations aren't left behind and that the benefits that people who are in more privileged positions in society are able to enjoy are also shared with those who don't get those benefits in life.
Well, thank you. That is such an important point, that there's a lot to celebrate, and I think that same goes for the universal health coverage topic, which is fairly new on the agenda of WHO, on the public agenda at least. And there's so much to celebrate, but we cannot give up and sit back on it, especially as COVID pointed out to us that there are many gaps we still have to fill. Maybe any points to celebrate on universal health coverage?
Absolutely. I mean, the life expectancy around the world, you've got a greater chance now to reach 80 plus than ever before. This wasn't the case after the Second World War. So huge improvements. In the last 20 years, almost 12 years added in life expectancy just in that period. Now, that is a celebration, but that's an average. And what we want to do is look at those who are living beyond the average and those who are not yet progressing and bring everybody up. That's why we're in public health. That's why we're here at the World Health Assembly, is exactly that.
And to come back to the basic human right of health being a human right, a basic human right. So I think that's a very good point to stop. We can celebrate many achievements, but we have a lot of work to do. The roadmap that you mentioned is coming up, the discussions we're having every time again, and at the assemblies, especially with the ministers, with the delegations from the members, to make sure that this level gets raised so that everybody can enjoy a basic line of primary health care, of health, and has it as a human right. I want to thank you very much for joining us here today. Dr. Shannon Barkley, expert for primary health care here at WHO, and Jim Campbell, our Director for Health Workforce here at WHO. And I want to thank you all watching us out there on Twitter, Facebook, LinkedIn, and on YouTube. And we had today contributions from India, from the DRC, from Canada, Ghana, USA, Nigeria, Mexico, Iran, Turkey, Kenya, Uganda, Philippines, Italy, Saudi Arabia, Belgium, Slovenia, Argentina, Guinea, Cambodia, Brazil, Greece, El Salvador, Cuba, Croatia, Niger, and I'm sure I'm missing one or two others. So thank you very much for joining live here from the World Health Assembly in Geneva. And you see in the background a lot is going on, and we're going back right there to the discussions with the ministers and the delegations to work for health. Thank you.
Thanks very much. It's a pleasure.
Thank you.